Hey everybody, welcome back to the ECG of the day. My name is Reid, and don't forget that before we get going, you can download the video or the PDF of today's video down in the description so you can follow along and make your own notes. And don't forget, if you enjoy the content, you can help support the page by liking these videos and subscribing so that we can get out there and get people to help learn some ECG. So let's get started. So the first thing I like to do when I look at an ECG is just get an idea of what we have going on. I look at the forest, and the trees of the forest are my QRS complexes. So I look maybe at lead 2, and I see I've got a narrow complex rhythm that seems to be pretty regular, and that's reassuring, and it seems to be that way throughout the entirety of the rhythm. I like when I see narrow complex rhythms to think that probably the conduction is coming through the AV node down this His-Purkinje rapid system that conducts the signal really rapidly, so that ventricular depolarization occurs in this nice narrow fashion. And so I look in front and I see P waves, and so I know that there's likely something coming from the atria down into the ventricles. And let's evaluate those P waves. And so what is my first step of depolarization is from the SA node giving signal off into the atria. And so I have P waves that are upright in lead 1. They're upright in AVF. That tells me that if it's coming from the SA node, it depolarizes down and to the left throughout the ventricles. And so I should see up in leads 1 in AVF. And so yes, that is a sinus rhythm. If you guys have been watching these videos for a while, I always start off my sinus node evaluation this way, and I find that it's a great habit to build. And so I kind of scan throughout, and I just glance and see, do my P wave morphologies stay the same? It seems like they do. And when you have a regular rhythm like this, sinus node behavior is usually pretty predictable, right? And so if we look at the rate of this sinus beats, we have a rate, if I find a QRS on a solid line, of 300, 150, 100, 75, 60, so maybe anywhere between 60 and 75. I'll call this 70 beats per minute, which is appropriate for the sinus node. Okay. The next thing that's going to capture the signal is my AV node, and I measure the AV node through my PR interval. And so I like to find a QRS that starts on a solid line. We can find one, perhaps, I don't know, we see a P wave here in V5 that seems to start kind of right on that solid line. And you can see the QRS complex is maybe one line past the beginning of that P wave. So maybe this PR interval is, I would give it probably 220 milliseconds. It's a little less than 6 small boxes. So my PR interval seems to be a little bit long. Just a hair, borderline long. We know our maximum that we like is 200 milliseconds, which is 5 small boxes. It's probably 5.5 small boxes. And so that tells me that the AV node is taking a long time to conduct, too long. So there's some type of AV block. But what type of block is it? First, second, or third degree? And the first degree block is characterized by every single P wave conducts through the AV node into the ventricles. And you can see that we have P's that seem to conduct throughout this rhythm, but you want to look in between and make sure that there are no P waves that are hanging out that are not conducting. I find V1 to be a pretty decent lead for this because my P waves are sharp and they're biphasic, and my T waves are typically kind of flatter and duller. And so it helps me to see a little bit of a contrast between my P's and my T's. I don't see that, and so this is a first degree AV block. And so we have our AV function kind of dialed in. Let's take a look at our QRS complexes. My QRS complex is narrow. We said it's less than, my width of my QRS is less than 120 milliseconds, or 3 small boxes. And so I'm happy with my QRS duration. My axis of my QRS is upright in lead 1. It's upright in AVF. That tells me that my QRS is traveling somewhere down to the left, where it would be positive in lead 1 in AVF, which makes me happy. That's where it should be going. It's a normal axis. And I've got good R wave progression, right? I have little septal R waves in V1 and V2, and they grow to become dominant here in lead 3, and then they stay positive in lead 4, 5, and 6, which is exactly what they should do. Sometimes when you see V3 become super positive, super fast, I would kind of guess that lead V3 was maybe not placed as appropriate. If this was like a patient that has a lot of breast tissue, sometimes people have a hard time placing them in the exact right spot, and that's okay. It's not going to change our interpretation. We can look at our QT interval. I sometimes just like to eyeball this. I take a QRS here and here, draw a line between them, and then I look at halfway through and I see, does my T wave end by the midway point of my R to R interval? And so it does here. And so I would say my QT is probably appropriate for the rate of this rhythm, right? Because QT intervals are corrected for the rate. And so that's just my eyeball test. And then lastly, I look for pathological Q waves and STT wave changes to see if there are any chronic or acute ischemic events. And as I scan through my leads here, I have my septal leads, I don't see any. I've got my anterior leads, I don't see any. I've got my lateral leads, which are lead 1, AVL, V5, V6, I don't see any. And then I can look also in the inferior leads, leads 2, 3, and AVF. And so I kind of scan through anatomically, and I don't see anything that pops out. And so now we're kind of done. We've evaluated all the aspects of the conduction system, from depolarization to repolarization of the atria and the ventricles, as well as the SA node and AV node function. And so what do we have? We have a sinus rhythm at 70 beats per minute with a first degree AV block. And that's what we have. Pretty simple. But at the end of the day, simple can be scary, right? If you don't know what you're missing. And so I find that remembering that the conduction system consists of the SA node firing off, the atria depolarizing, the AV node capturing that signal, delaying it for a split second as the ventricles fill from that atrial contraction or the atrial kick. And then the QRS is created when the AV node passes that down after around 200 milliseconds. And so we get a nice narrow QRS if they travel through our His bundle, left and right bundle branches, the left anterior and posterior fascicles, depolarizing from endocardial to epicardial, and then repolarizing from epicardial to endocardial. So we get all these predictable waveforms that we measure and can be confident in what's going on. So I hope this video helps. If you have any questions, put them down in the comments below, and hope you like it. See you tomorrow. Have a great day.